Okay, it's right at 7:30, so I'm gonna go ahead and get started. And when people join, that'll be great. And then if you're watching this later, that's great too. So I'm Caroline Sullivan. I am one of the adjunct faculty for this course, and I also am clinical faculty. So have some of you guys in clinical, so that's great. I hope that y'all have had a great week, um, and that you're just getting over that hump day, and that you're looking forward to the weekend. I cannot believe the semester is more than halfway over. It'll be here before we know it. So you guys keep up the good work, and it'll be here before you know it. You'll be moving on to the next course and to graduation and all that good stuff. So not today, tonight. Let me get my time right here. We're going to be talking about skin conditions. So fun. So I'm going to try to share my screen with you guys, and then we'll get started with my PowerPoint. There's lots of pictures. Anytime we talk about skin, we got to have lots of pictures. So hopefully you're not like eating dinner while you're watching this, because some of these, skin's just not the prettiest thing to look at all the time. So when I was making this, I was actually in clinic and my door was open and people would be walking by, and you'll see in some of these pictures, it's just not the best looking thing. And so I'm like, maybe I should shut my door, because people are probably like, what in the world is she doing? What is she looking at? All right. So all of the information we're going to be going over tonight is from chapter 37 in your Burns book. So if you have any questions whatsoever, go back to the Burns chapter 37, look over that. Charts and tables that we'll look at tonight are from that chapter, and there's a lot of other things there. I tried to keep it as simple as possible. Skin conditions, there's just a lot. There's so many to go over. So I tried to narrow it down to things I felt like you would really see a lot of in clinic, that you just the kind of the core things that you need to know. And just know there's always going to be those crazy things that, we didn't really go over when you were in school. You're going to be in practice. And you're going to be like, what in the world, is this? Skin things can be that way. You're like, oh no, another rash that I have no idea what it is. So that's when you go and grab your resources and your books and your colleagues and friends and get on up to date and find answers. All right. So this is kind of how I've broken it down. I know this seems kind of busy, but this is just a way to break things down and kind of give you a picture of what we're going to talk about tonight. So looking at the 5 different branches of common skin disorders, we have the bacterial, fungal, infestations, fun, viral, and then allergic and inflammatory. So that's the 5 core areas we're going to touch on tonight, and then you can see underneath there the things that we're going to hit on. So first we're going to look at bacterial and impetigo. Such a fun thing when you see it. It can be really mild, but it also can be really severe. I remember seeing about 8-year-old little boy in clinic years ago, and it was a severe case. It was covering his entire face. We had to get on some strong oral antibiotics for that, so that it didn't get out of control. Well, I think it was already out of control, but so typically Staph aureus is going to be the main cause of impetigo infections. And you can see in the picture, it's got that honey-colored crust over it. That's really what you're looking for here to kind of differentiate between other things. So has that erythematous base, got that red kind of sore, but then we've got that honey-colored crust over it, or like blisters. And so those blisters will end up breaking over time. So it involves just the epidermis, so really just that top little layer of skin. We're not going to have like deep infections from this. If we're having anything past the epidermis, then you can pretty much know it's probably not impetigo. Really, you can just do a topical antibiotic like a mupirocin ointment, but if it's a large area, like I talked about with this little boy who had it just covering his entire face, then you'd want to go for some oral antibiotics and not prolong things. So typically with that, Augmentin, Keflex, Clinda, those things are going to cover that Staph aureus really well. So those are the things that we want to treat with if we need the oral. But like I said, you can start out with the topical if it's just like a small area. Next in the bacterial department, cellulitis. So in children, I feel like this is not seen quite as much as it is in adults, but still need to know about it. So typically it's going to be group A strep that causes this. The major hallmarks you're going to see: swelling, tenderness, and red. Obviously irregular borders is up there, but I feel like the main things you need to know: swelling, tenderness, red. And then if you want to put something on top of that, warmth. So when you put your hand on it, on the skin, it's going to be radiating heat typically. And it's, like I said, really tender to the touch. Like when you go to palpate it, they're going to like pull away from you and wince. And you can see in this picture, kind of talking about the irregular borders. So it's like darker red in the middle, and then it just kind of fades out, and it's not really differentiated really well, like a typical bacterial wound would be. So that's when we know we got the cellulitis going on. Also can have that orange peel appearance. So like the little dots in the skin, it can start looking like that. So this does involve the dermis, but then also sub-Q tissue. So remember, impetigo just affects the epidermis. Superficial, this can go deeper than that. It can become a really big problem if we don't take care of it. People can become septic with this if it continues to spread and we don't treat it, which if people don't seek treatment, it will continue to spread. If, you know, probably in this person, it started in one little area and then it just kept creeping and creeping and creeping up and up and up and up. And it would keep doing that if we didn't start any medication. So best things for cellulitis is going to be augmentin and Keflex. That's going to cover the group A strep really well. I want to keep a close eye on these patients. I always follow up with these patients, depending on how severe it is, like within a week or 2 weeks, because you want to keep an eye on it. It's not something you want to just let go and be like, oh, come back, it's not getting better. It's like, no, we need to go ahead and just like make you a follow-up appointment so I can keep an eye on it. And you can see this person has like a marker line on the top of their leg. That's a great idea because that's going to help us know if it's spreading or not. So you can use the marker, you know, kind of outline it when you're in the clinic and tell the parent, you know, in 2 days, this should be getting smaller. The redness should not be extending past my marker lines after we've started the antibiotic. If it does, then we need to know about it. Next in the bacterial department is folliculitis. So Staph aureus is typically the cause of this. Staph's the cause of all these bacterial problems, good old staph. So it's going to be really itchy, and there's going to be these little papules or pustules. Typically when I see it, I feel like it's more pustules. So in the picture, you see those pustules there. They have that really red, irritated base, but then the pustule, and see the hair coming out of the little pustules there. That's because folliculitis, as the name tells you, involves hair follicles. So you can see in the picture, in the top picture, this person looks like they shaved pretty recently. And that can be a trigger for folliculitis because you get those ingrown hairs as they're trying to grow back in and they get stuck, and that's what's going to cause it. So treatment for this, warm compresses, that's going to help, you know, open some of these areas up, and then also topical antibiotics. So I usually like to use clindamycin with my patients. And then education is a big thing with the folliculitis. Can get it on the face, but then also people do get it under the arms quite a bit, and even in the inguinal area, especially women who, or teenage girls who shave their pubic area are going to have this problem, can have this problem. So some people have it quite often. So I like to do clindamycin and, like I said, doing the warm compresses. Now, if this ever turns into like an abscess, then it's definitely more, I'm sorry, my dog's over here shaking. It's definitely more than a folliculitis. We just want to keep an eye on that. And then education on shaving practices is important because we want to tell our patients to switch out their razor heads often. Obviously, if they've shaved their face with this present, these pustules and this infection present, we need to throw that razor head away. We don't want to keep spreading it. So change out razor heads often. And then also, a lot of times patients are going to have to limit the amount of times they're shaving. So I've seen a lot of guys who like they might shave every day and then they have this problem. And so they're just gonna have to space it out some, until things get more under control. So just try to avoid shaving if possible during this time because that's really just gonna irritate it. So next, move on to fungal infections. Let me move this over so that y'all can see my lovely pictures. So we know really the biggest thing fungal when I think of in little ones is yeast. So the candidiasis, it's what we'll see quite often, starting from when they're little, starting from when they're babies. We'll get the diaper yeast rash, and then we can just have problems with it throughout. So yeast is a normal part of our body's typical flora. Like it's healthy to have yeast present. The problem is when we have the overgrowth of yeast. And as you all probably know, this typically starts in the stomach. So gluten and all those, yummy foods that are bad for us, they cause yeast to overgrow in the stomach. And that starts opening up like the pores, the openings in like the lining of our stomach, kind of like our sac that goes around our stomach. And then we start to leak, good bacteria out and even nutrients out that we eat. And so yeast overgrows and we start having these manifestations, everywhere. So in skin folds, or for ladies, they can have it, vaginal yeast, you have it in the mouth, things like that. So white plaques are what we're looking for, and they can have an erythematous base. Typically they will. It can be harder to see that in the mouth. If it's on the skin, then you'll be able to see the redness, but if it's in the mouth, it's harder to tell. Or if it's on the like genital area, it can be harder to tell, but you'll definitely usually see that white plaque. And if it's like an oral yeast, then they'll have a film over their tongue. So oral thrush is treated with nystatin, the suspension, and then the skin rash, so like that picture under the arm, and then also like in the diaper area, we treat that with a topical antifungal. So ketoconazole is what I typically use. It's one of my favorites, but also clotrimazole. Can use that. Nystatin topical, your book lists that. I've just found in practice that that's not always as helpful as ketoconazole or clotrimazole, so I don't usually use that. Just something to keep in mind. Biggest thing with yeast is education, because yeast is really hard to get rid of a lot of times. It just grows and grows and grows, and it spreads on things. And so it's hard to get rid of. It can get on our clothes, and then even when we wash them, it doesn't go away unless we wash them in like warm water or with vinegar. If you have a baby that's having a yeast diaper rash or thrush in the mouth, we've got to be sanitizing their bottles, their passies, the nipples, anything that's going to go in their mouth. We've got to be boiling it after each feed, because that's how yeast is going to spread. So just as an example, I had a patient who was a few weeks old, and the mom called the office and said that she had been diagnosed with a yeast infection on her nipple, and she was breastfeeding, and she did not notice any problems with the baby. She said she might have seen white patches in the mouth, but it was really hard to tell, but no diaper rash or anything like that. So even though the baby wasn't necessarily having symptoms, because the mom had a diagnosed yeast rash of the nipple and was breastfeeding, we went ahead and treated the baby with the nystatin oral suspension, because you can imagine, if we're talking about the yeast spreads really easily and really rapidly, and it's really hard to get rid of, it's just a matter of time before the baby gets it, because the baby's latching onto the nipple, that yeast is getting in the mouth, they're taking it in, and then when they poop, it's coming out through their poop, and so then they're going to get a diaper rash. So it's just like this whole cycle effect. So we treated with the nystatin oral, and we didn't have any problems. So that's something to always keep in mind. Washing clothes, this happens in the skin folds. A lot of people, if they're overweight, they can get it typically under that abdominal pannus, that fold. And that's just because yeast loves to grow in warm, dark, moist places. And under a skin fold is all of those things. So under arms, under breasts, if women have large breasts, this can be worse in the summer because you're sweating, so there's more moisture. So I like to tell people, if they can, just to air it out. If you have a baby with a yeast diaper rash, like, as if you can, let them go without a diaper for maybe just like 15 or 20 minutes. Frequent diaper changes. Don't let babies sit in moisture. All those things can be helpful. Next portion of the fungal is ringworm. So fun. So we're going to talk about a few different types of the tinea, but first we'll talk about the tinea corporis. So that's the ringworm. So here's a lovely picture of it. I'm sure you guys have all seen this, but it's going to be really itchy. It's going to be red. It's going to be circular typically, and it's going to have a pretty well-defined border typically, and it's going to be raised up a little bit. So in the middle, there might be some central clearing, and so really just around the border, you'll see like those are erythematous, like raised portions. And so in the middle, it could be cleared a little bit, but definitely well demarcated. So nice little border around it. We'll treat this with topical antifungals, like we talked about, the clotrimazole or the ketoconazole. Some cases can be really resistant, like we talked about. Yeast is really resistant, so is tinea. So funguses are resistant. It can be hard and time consuming to get rid of these. So sometimes if we can't get rid of it with the topical, then we'll have to do the oral terbinafine. And just remember that can alter liver function. So we have to check liver function before we start on the terbinafine oral. And this is really contagious, so definitely want to limit exposure to other people if possible. If the child is in daycare, then we want to let the daycare know. And typically the recommendation is not to send them back until it's scabbed over and clearing. So just keep that in mind. Next is the tinea cruris. So this is going to be pretty similar, but just kind of bigger. It can have scaly portions of it. It's going to be raised up just like the ringworm is. You won't see this on the genital area. You can see it on the upper thighs and groin. Same treatment as the tinea corporis. So topical antifungals. Big thing here is telling our patients to try to wear loose clothing. Your book talks about doing absorbent powder if needed. That's not something I've ever recommended to my patients in clinical, but your book talks about that. So, that could be helpful. You just want to make sure it's talc powder free. So just to help absorb moisture, that could be helpful. These pictures, you guys, goodness. Tinea pedis, so this is fungal infection of the foot. We'll see vesicles and erosion on the instep part of the foot typically. So you can see in that top picture, it's just a really bad fungal infection. You'll see in between the toes, there's a lot of redness. There can be scaling. And then where, the weight, where you put weight bearing on your feet. So look at the baby picture at the bottom, where the most red portion is. That's where we might see it mostly. This is a baby, so they're not walking, but just on somebody that is walking. So this can be easily confused with hand, foot, and mouth. So we don't want to confuse that, because obviously hand, foot, and mouth doesn't need treatment. So we don't have to, give them, that would be a waste of topical antifungals. We'll go over, let's see, I'm trying to think, do we go over hand, foot, and mouth? I don't think we do. I don't think I included that. But hand, foot, and mouth can look similar, can have like just the little vesicles, and it can be kind of in between the toes. It can be kind of red. The biggest thing here is that you'll see it, just like it says, on the hands and the mouth too, typically. So, if it's just the feet alone, and they're not having any other symptoms, like viral symptoms, then you can be kind of positive it's not hand, foot, and mouth. If they're having other symptoms like low-grade fever, nausea, vomiting, diarrhea, then you need to take into consideration hand, foot, and mouth, do a good oral exam on them. So treat this the same way as we've been talking about, topical antifungals. If it's severe, like in that top picture, then you'd want to do the oral terbinafine. And open-toed shoes is a recommendation. That is just to get more air. So air, sunlight, because we know that funguses like to grow in warm, wet, dark places. And then reinfection is pretty common. So you can tell your patients, this may come back. This may be something that we kind of deal with on and off for a while. Because like we said, it's hard to get rid of. The next, and possibly last, I can't remember, fungal skin condition we'll talk about is tinea versicolor. So you won't see this too often, but I want you to know what it is, because if you've never learned about this, I didn't specifically learn about this in school. And I remember the first time I saw it in clinical, and I was like, not in clinical, in practice. And I was like, what in the world is this? I've never heard of this. I have no idea what to do. So I want you to know what it is, because when you see it, it's easy to identify, it's easy to treat. You know what it is and can move on. So tinea versicolor, I've included pictures of a lighter skin person and a darker skin because it can look a little bit different, but it's hypopigmentation basically. And then in some areas it might be hyperpigmented. And in the summertime, it's not going to tan like your other skin. So it's going to be almost like somebody splattered sunscreen on you. It can be kind of scaly and easy to get rid of. We can just do the selenium shampoo. So basically Selsun Blue or ketoconazole shampoo. You can do that too. But they have to bathe with that. And it can take a while to get rid of. All these funguses, just keep that in your head with funguses and fungal skin conditions. They can be hard to get rid of. So with this, unfortunately, there's a 50% reoccurrence rate. So educate your patients on that. Like maybe just keep the Selsun Blue handy at home so that when it comes back, they can be ready and treat it before it gets, like these kind of out of control. All right. Now, if this picture doesn't make you itch, doesn't make your head itch, I don't know what will. When I was making these slides, I was itching all over. Isn't that how it goes? Whenever I'm in clinic and I see a rash, I always come back to my office and I start scratching and I'm itching. I'm like, it's all mental. Okay, so next we're talking about infestations, just a couple things here. Obviously lice, you're going to see that in pediatrics, so you need to know about it. You can see here in the picture, you're going to be able to see the little nits. They're going to be white and a lot of times they're moving. So some people have concern that they could misdiagnose this if it's like dandruff or something, but I've never had that issue. I don't think you will, because like I said, the nits are typically moving around, and they're all the same size. And dandruff can they're flaky and they change in size. Some pieces are big and some pieces are really small. So the best method to treat is just making sure that parents have the proper technique to get rid of this. So if they're not doing all of these things, then it's going to be really hard to fully get rid of this. So the first thing is to apply the permethrin. Permethrin is always what I prescribe. But it's the same, the pyrethrin there plus the pyperonol butoxide. So they're going to apply that to the scalp, and sometimes they can be in the eyebrows, or if guys have beards, they can go and be in the beard. So apply it wherever they are. And then you want to remove the knit. So they do make special, you see me, I'm already scratching my head. They do make special combs for getting out nits, but you can just use a regular comb, kind of just whatever you have. But we need a fine tooth comb to get through. So it's going to take a lot of time. You just go tell the parents, you just go through just 1 inch little sections and just look and look and look and look and make sure you get through every little piece of hair and remove. So you can just get a little bowl. People typically just get a little bowl, maybe put some alcohol in it, get that fine tooth comb and go through and then just put it in the bowl. And then the third step is to clean the environment. This is very important. So obviously check family, because these things spread like wildfire. So you want to let school know, let daycare know, because other kids may have it. That's where your kid may have gotten it, where your patient may have gotten it from. Definitely want to clean sheets, towels, clothing. If they wear helmets for sports, we want to check all of that because we don't want this coming back and being something we can't get rid of. So wash clothing, bedding, all that in hot water. The book recommended storing other items in plastic for 2 days. And then vacuuming any carpet, obviously, vacuum really well because they can be in the carpet. Soak brushes and combs, and then follow up in 2 weeks with a daily recheck at home by the parent. So, proper technique is key. So, they can go back to school after they do the permethrin treatment. No nip policies are not recommended. That's what your book had said. So, if they've completed the permethrin treatment, they should be able to go back to school. So just keep that in mind. I'm sure schools have different policies on it, but so we have to just follow those. Okay, so next, infestations, scabies. This is something I used to see a lot of. I was so proud of myself because I became an expert at pointing out scabies because I worked in a really rural clinic and my patient population was just very diverse. And I saw, a lot of homeless people, a lot of migrant people, people recently out of prison. It was very interesting. And I saw a lot of scabies. And so I could pick them out just like, that. So I was very proud of myself, considering myself a scabies expert. So you're going to see these little, they're always described them as S-shaped curves, but in clinical practice, I feel like they're not always S-shaped curves. Like I was looking for that and I just wouldn't find that. To me, it's just really like this top picture here. I feel like on the bottom, we do have some S-shaped curves you can kind of see. But at the top, that's more of what I see in clinical. You can tell something is just like burrowed under the skin. And we have these red places and they're kind of peeling up. So these patients, they are going to come in telling you they are scratching themselves to death. They are going to be very itchy. Scabies is very itchy. These patients, some of them won't have slept the night. You see, I'm scratching my neck now. These patients will sometimes say they haven't slept the night before because they are up all night just itching themselves to death. So their skin can be really red, can be scratched up, and then you'll see these little kind of burrows under the skin. And typically these are going to happen in like skin folds. So I always used to see it on people's wrists and a lot of times in between the fingers. So like right here, here, and then a lot of times, in the elbow here. I have seen it get so bad where it just is covering their whole abdomen because they just kind of let it go and didn't know what it was. So it can get to that point, but typically you'll just see it in those little places there. And in feet, in between the toes, and those little places behind the knees. Yes. So in infants and young children, sometimes instead of like the little burrows, they can have these vesicular pustular lesions. You can see that on the foot on the bottom there. So just look out for those. Looks a little bit different. We treat this with the permethrin creams, the same thing that we use to treat the scabies, the lice. And what they're going to do is put a thin layer over their entire body. Obviously, don't put it in their eyes. And they want to make sure they're putting it on their scalp, behind their ears, in all of their skin folds and creases, on their feet and hands. And then they leave it on overnight and then they get up and shower the next morning. And this can be reapplied. Typically, people do well after just one dose, but this can be reapplied in 7 days if they feel like it hasn't fully gone away. These people, like I said, are going to be itching really, really, really bad. So if you want to prescribe, you can tell them to take Benadryl if they want to, or if you felt like it was like affecting sleep, we could always try like hydroxyzine if they're older. So now we'll move on to the viral portion. We're moving right along. HSV type 1. So HSV in general could really be its own talk. So I'm going to try to keep this as brief as possible because there's a lot to talk about with HSV, but we're just going to talk about type 1 first. So type 1, these are not considered sexually transmitted HSV. Okay, because you don't have to have sexual contact to transmit HSV type 1. You can get this just from direct contact with the secretions or with the little lesions themselves. So, I mean, like somebody kissed a baby and they had HSV1, then they would spread it. So technically, it's not considered a sexually transmitted disease. This can be really hard to explain to patients, saying like, you have HSV, but it's not the type 2. And they're like, wait, I have herpes? Like what? So it takes a lot of education. But you're going to see these little vesicles. They look like little blisters. HSV type 1 is typically going to come up on the mouth. And in the beginning, there's like this little prodromal phase where it's really painful. It's burning, tingling. It may even feel a little bit numb, and it can be a little itchy. Sometimes if it's really painful, and it's affecting like, just their daily life, then we could do viscous lidocaine. If it's like internal in the mouth, that they can kind of swish around and just put right on that spot. Or if we felt like, if it's on the lip and it's turning into a bacterial infection, maybe they've been scratching it a lot or picking at it a lot, and the bacteria from underneath their nails cause a bacterial infection, then we would need to do a topical antibiotic for that. But the main way we treat this is just the antiviral. So acyclovir, valciclovir. And then type 2, I know this is not a great picture to look at. I'm sorry. So this is HSV type 2 on the vaginal area. And so obviously it looks very different than what HSV looks like on the lips of the mouth. So, it's like here it talks about grouped vesicopustules and ulcerations. I usually see, that's what they look like. That's what I would describe them, ulcers. Sometimes they can be blisters that haven't busted open yet. When they do bust open, they look like an ulcer. So they're usually really painful, like an ulcer too. So patients will complain that they're like burning really bad. They'll say like, I can't even, wipe after I go to the bathroom. I can't even sit down because it's just burning so bad. Typically females are going to get this on the vaginal mucosa and on the labia, sometimes the perineum. I typically see it on the labia. And then males can get it on the penile shaft itself. So women can have cervical involvement. That's kind of rare. I've never seen that, but it can happen. And then also this can be transmitted to oral lesions. So if someone has engaged in oral sex with somebody that has HSV2 lesions on their genitals and they engage in oral sex, then they then can develop the HSV2 in their mouth. So just keep that in mind. I know it gets confusing between 1 and 2. And infections like this, if they become kind of severe, can cause lymphadenopathy. So you may see if someone has some genital lesions that they have like an inguinal lymph node that's enlarged and painful. So we treat this with the oral antivirals. And I put educate because you guys, people just don't understand how HSV spreads, and we need to take the time to educate. So set aside time to let them know that you can spread HSV type 2 when you do not have any active lesions, and also take the time to educate them that unlike chlamydia, gonorrhea, you're not going to take the medication and it's going to go away and it's cured. This is something you will have forever. It's a virus. We cannot get rid of it. It's going to forever be in your bloodstream, and you're going to have flare-ups. This is a chronic condition. You can't, just call them and say, oh, by the way, you tested positive for, HSV2. Bye. This is going to take education. This is a chronic problem. You're going to have flare-ups. You need to have protected intercourse because you can spread this even when you don't have lesions. A lot of HSV2 patients think that they can only spread it if they have active lesions. That is not true because the virus can be active before the lesions have shown up if they're having a flare. So, this is how it spreads. People just don't know. I've had a patient, he thought that it was just like any other STD. You take an antibiotic and you get rid of it. It's gone forever. And I had to educate him and tell him, no, that's not how it works. And he said, what? I'm going to have this forever? I said, yeah. He said, you can't just filter. They don't have a machine you can plug up and filter out my blood and filter the virus out. I thought, that's a good idea. But no, we don't have that yet. We have a dialysis machine, but that's not going to take the virus out. So anyway, education is really big in HSV type 2. The next viral thing we'll talk about is warts. I'm sure you guys have all seen this. So you may have dealt with this personally. So warts, this is kind of controversial, but most sources tell us that warts are contagious and that, you get them by exposure. So often, many times these are going to be hard to get rid of and recurrence rate is high. So even if we, here we talk about treating with the salicylic acid that you paint on, and you want to make sure that they get at least the 20% concentration of the salicylic acid, but they have to do this twice daily, every day for 6 weeks. And even after that, it's not a guarantee that, it will fully go away. Cryotherapy is an option. This is obviously not well tolerated in children because it can be painful. And even with cryotherapy, there's a high reoccurrence rate that's going to come back. So sometimes it requires surgical excision if that's something that your patient or their parent wants to do. That can be done at dermatology. Or if you are going to do that in your office, I don't cut out warts, but personally, I know people that do. So yeah. Moving on, molluscum. So this is a common problem. Now, this can be confused with warts, and you can see, they look similar, flesh colored, sometimes they're pink, they're kind of like little papules. And sometimes after they progress, not kind of a gross description, but they can have a cheesy core if they just grow and get bigger. So these are totally benign. Parents will come in and be like, oh my goodness, my child is eat up with something. We got to do something. But we want to just reassure them that molluscum is benign. They don't pose a risk, to their health, and they're not easy to get rid of. They're not easily treated. So there's some options. You can do silver nitrate on them. Cryotherapy is not really a good option because, as you can see in this picture, they're typically just widespread. There's going to be a lot of them. So, you can try the silver nitrate sticks. A lot of times they'll just go away on their own. Children typically grow out of these. So really it's more about reassurance to the parents. So next, we'll go into the allergic and inflammatory. So we're almost done. We'll talk about acne first. So this is kind of the process of acne. So starting where the star is. So our sebaceous follicles in the face or the back, wherever your patient's having acne, the sebaceous follicles, your sweat glands, become plugged with keratinous material. Then colonies of bacteria start growing in that follicle. Sometimes, it lists here the different bacteria that it can be that start growing. Then what happens, your sebum is overproduced because it's stopped up. Your sweat gland is in the follicle is stopped up. Androgen production increases, resulting in expansion of the follicle. So the follicle starts getting bigger, it starts getting swollen, it's plugged up with this sebaceous material that your body's trying to produce and get out. Then inflammation occurs, pustules form, secondary to the trapped bacteria. And it's just this cycle over and over again. So you may pop it and it may open up, then the same cycle, just keeps happening, these sebaceous follicles becoming plugged. These are some pictures that you can look at to go off of to categorize the acne that you're seeing: mild, moderate, inflammatory, or severe inflammatory. Something I want to make sure you know about is just whether it's inflammatory or not. So There is non-inflammatory versus inflammatory. You can see in the first picture, there's really not a lot of erythema there. I mean, it's just kind of like little pustules. In the second picture, you can kind of see there's this generalized slight erythema going on. And then in the third picture, you can see there, I mean, the face is almost, or wherever this is, I think it's the face, is almost covered in erythema and the swollen areas. So that's what makes it inflammatory or non-inflammatory. So treatment for acne, there's lots of over-the-counter stuff that people will typically try. But number one, we want to make sure that people are washing their face every day, every morning, and every night. So teenagers, especially teenage guys, I find they are not washing their face. I don't know why, but they're not. They're washing their body, but they're not washing their face. And so make sure that your patient's doing that, because that will help tremendously as we're trying all these medications to try to help them. So we want to get them on a retinoid. So Differin gel is a common one. You've probably seen a commercial for that or seen it in the store. They can get that over the counter. So it used to be prescription, but I think you can get it over the counter now. So we want to get them on that, and they just put that on the places they have acne. So we want to get them on a retinoid. If that alone is not helpful, then we want to move to a topical antibiotic. So we want to keep doing the retinoid, the Differin gel, if that's what you choose or your patient chooses, and then we'll add clindamycin topical. And why are we doing the antibiotic? Because we just talked about that those sebaceous follicles that are plugged up, bacteria starts colonizing in them. So if we can prevent that bacterial colonization from growing and growing and growing, then we'll kind of put an X little stop in that cycle that we just looked at, and we can kind of, work backwards. So if that is not helpful, then we add benzoyl peroxide. Now, they do make a topical you can prescribe that's clindamycin with benzoyl peroxide. That's typically what I do. I typically don't separate the two. If I'm going to do something past the retinoid, I'll just go ahead and prescribe the clindamycin and benzoyl peroxide that's in one topical treatment. If that is not doing it, and we've got the severe inflammatory, nodular, cystic acne, then we may need to do oral antibiotics. And your doxycycline and your minocycline, that's going to be your best options here. Very last option would be like Accutane. And, this is only reserved, like I said, for severe acne. And this would not be something that I would even prescribe personally. If a patient has gotten to this point, I would have already referred them to a dermatologist to manage this. So if a patient is on Accutane, have to make sure if they're a female that they are on birth control or that they're not sexually active, because this can cause severe birth defects if you got pregnant while taking this. Okay, sweet little baby. Moving on to dermatitis, there's a few different types. First one we'll talk about is the seborrheic dermatitis, or cradle cap, in babies, as it's called. It's not always in babies. It can be in older kids and older people. So there's going to be like an erythematous kind of base, and there's going to be these flaky, thick, yellow, like greasy crusts. They might have like a waxy appearance to them. Typically the scales are going to be on the top of the scalp. They can also be like I've usually seen them like along the hairline too, or like back and through here, behind the ears, on the neck, in the diaper area. In infants, this is pretty self-limited. Like if it's cradle cap, if they're a newborn, they have this, then typically we just say, they can get like a little really soft-haired bristle brush. And when they give their baby a bath, they can just put some baby soap on there and, scrub their little head, and it just helps loosen up those flakes and move them. And typically it goes away and it's not a problem. We don't have to do any treatment. If this is an older child and it's really itching them, and it's becoming a problem and it's spreading, then we need to treat it. So if they're over 2 years old and they're having this problem, then we can use ketoconazole topical or shampoo. So if you have a patient that just has it, like on their face or on their scalp or behind their ear, we can just do the topical. If it's also in their hair, then we need to do the shampoo along with the topical. ketoconazole. Next is atopic dermatitis, which is eczema. You will see a lot of this if you are going to work in a pediatric practice. So, look at that little boy at the bottom, Indian doll. Oh my goodness. Sorry, my little boy just turned 1. So anytime I see a baby, I'm just like, oh, so cute. So this is chronic. This is going to be recurring. You can go ahead and educate parents and patients. This is, it's not like a one and done type thing with eczema. This is going to be a recurring thing. So it's something we need to always be looking out for, because you don't want it to become like a flare-up, to become out of control, and then we have to get on steroids frequently. We don't want to have to do that. So this rash is going to be really itchy. It's going to be red, scaly. It's going to be in the skin folds, typically, like you can see there. I think I'm trying to decide, is that the elbows or behind the knees in a skinny child? I'm not sure. But that's typically where you'll see it. In babies, you see it on their face, like the picture down there. You can see it on their back. My son had it on his back when he was, I think 4 months old was the first time I saw it, and it was just really small little places, and eczema was like not even on my radar because it was on his back, and I never really thought about eczema being on the back. But we started moisturizing him with some eczema lotion, and yeah, got that under control. So management of this is preventing the itch scratch cycle, because we just said this is really itchy. Kids are going to scratch it, and it becomes this cycle of they're breaking down the skin barrier because they're scratching. They can get actually bacterial infections in their flare-ups if they scratch and they have bacteria under their nails. So we have to watch out for that. Management and prevention is moisturization. We want to moisturize these babies, moisturize these children. We want to keep the skin moisturized, and we do not want the skin to be dry, because that's going to make it more itchy, and that's going to just make our problem worse. So Aquaphor is what I recommend to all of my patients. I don't know if you've ever heard of Aquaphor. If you have not, go do yourself a favor and buy some Aquaphor. It comes in a tub, and it has like a navy blue lid on it. You can get it anywhere in the lotion section, and it comes in like little squeeze bottles too. It's great stuff. It's like Vaseline, but not as greasy, and like thicker, if that's possible. But it's great for eczema. So I tell parents, to put on the Aquaphor at night before they go to bed, before they put the pajamas on, and then go to bed in Aquaphor every night. And you can get lotions for eczema. Cetaphil makes great ones. You want to make sure they're not using anything with allergens in it. So like soaps, laundry detergents, lotions, non-scented, hypoallergenic. You need to ask the parents, what are you using to wash the clothes? Because, they may be using all these scent boosters and fabric softeners that have all this smell good stuff in it, and dryer sheets that smell so great. And that's great, but that tears up the skin a lot of times. So we need to just go down to, the non-additive laundry detergent. Sometimes the kids may require an antihistamine at nighttime if they are just scratching themselves and they're like, it's interrupting their sleep. Then we could prescribe like some Zyrtec for them. And then also if, we have a flare up that's not being well managed by moisturization, then you can do a topical steroid, low dose and only for short periods of time. Here's a little chart of topical steroids. Going from the bottom up, going from mild to potent. In children, remember, their skin is going to absorb, it's thinner. So it's going to absorb more steroid than an adult would. So we always want to stick to low doses with children. Hydrocortisone, the 1%, you get that over the counter. That's the lowest type, steroid topical that we're going to have. Going up, you can prescribe the 2.5 ointment of hydrocortisone. Triamcinolone is probably what you're going to see most often. I think people just pick, things that they feel most like they just get in a groove. That's my thing, triamcinolone cream. the 0.1%. And that is on the potent side. So that's if something is, really severe. So clobetasol is another one you'll see probably quite often. That is on the potent side as well. So really with kids, you want to stick to hydrocortisone because unless it's severe, because like I said, their skin is thinner, it absorbs more. The next thing we're going to talk about with allergy and inflammatory skin conditions, and I promise we are almost done, is psoriasis. So this is an immune-mediated disorder, and interesting, they found a chromosome that is linked to the development of psoriasis, and then they've also found certain triggers that they found contribute to people developing psoriasis, which include infection, local trauma, physical and psychological stress, and then certain drugs. So beta blockers, lithium, NSAIDs, and steroids, which is interesting to me. But typically this is going to occur on the scalp, elbows, knees, sometimes the buttocks. And if it's an infant, it's going to be, it can be in the diaper area. So in children, this can also pop up on their face. And plaque psoriasis is going to have that well-marginated rash that has those silver scales on it. So the Auspitz sign, you'll probably all heard of this as well, but that's when you can just kind of scratch off or pick off a little scale and you'll see blood start coming up. So that's a positive sign, the Auspitz sign, that this is psoriasis. So you can see in the top picture, it's around the hairline there. Treatment for this involves steroid cream, moisturization, and interestingly enough, sun exposure. So we want to be as conservative as possible with steroids in pediatrics. So just keep that in mind. We really only want to use it when it's severe and absolutely necessary. The next allergic and inflammatory rash we'll talk about is the diaper dermatitis. So erythematous, obviously, bless these children's hearts. There can be some edema, some swelling. I mean, you can see in that right picture, there's definitely some edema going on, poor thing. So it can, over time, if it's been going on for a long time, you can see some scales and even some areas of decreased pigmentation. So I feel like that right picture, I mean, that's a severe case. I've never seen a diaper rash that bad. But on the left, that's typically what you're going to see in clinic. That's what I typically see in clinic. The best way to prevent this is frequent diaper changes and leaving open to air whenever possible. And I know that's hard to do with babies because you don't want them going to the bathroom everywhere. But, maybe after they've just gone to the bathroom, then you can feel comfortable to leave them open to air a little bit. So if needed, you can do hydrocortisone if it's bad, but really what we'll use is just a good barrier cream. So you can use Aquaphor for this too. Aquaphor is a great barrier cream, but then also just like normal diaper creams. There's like Desitin. Everybody kind of has their favorite. So we want to keep that barrier there because we don't want moisture to be sitting on the skin. And then you can just use a mild soap to clean. You do not want to scrub these areas because that's going to make it worse. And it's going to make the poor little baby scream and cry. All right, that is it, you guys. I'm sorry that kind of was longer than I hoped it would be, but hopefully this was helpful and kind of covered the common skin conditions that you're going to see. If you have any questions at all, please feel free to reach out to me now that we're all scratching ourselves and feeling really itchy and like wanting to go take a shower. Yeah, let me know if you have any questions at all. Thank y'all for watching this. And I hope y'all have a good rest of the week. Reach out if y'all need anything at all. All right, guys. Bye.